Welcome everyone to the second session on the last step in the PECUNIA concept, the valuation part. This session is entitled Comparing Apples with Apples at Last, the PECUNIA Reference Unit Cost, or RUC Compendium. I'm Judith Simon from the Medical University of Vienna, and I'm going to be chairing the meeting. After 5 presentations by colleagues, there will be a live question and answer session. So the first presentation, the introduction to this part of the work, will be done by my colleague Michael Berger at the Medical University of Vienna. He will also present the PECUNIA RUC Compendium part on health and social care. Irina Pochilenko from the University of Maastricht will present afterwards the part of the compendium on education and criminal justice. Kimberly Hubens from the Erasmus University will present the part of the compendium on employment and productivity, and Valentin Brodsky from the Corvinus University Budapest will present the part on patient, family, and informal care. Enjoy the session.
Thank you very much. My name is Michael Berger at the Medical University of Vienna, and I will provide a short introduction to the PECUNIA RUC Compendium. I'll start with a little background to better understand the nature of the PECUNIA Reference Unit Cost Compendium and what it can offer to the scientific community. And what better way to start a presentation than with a list of definitions? First of all, what are unit costs and why do we need them? Unit costs are the average monetary value of a unit of resource use. For instance, a visit to your family doctor. So far, so abstract. But to economists, this number is extremely useful to assess the economic impact of illnesses, novel treatments, or policy changes. However, unit costs are not everywhere calculated in the same way, which results in the problem of comparing apples with oranges. And this is where the reference unit costs come into play. Reference unit costs, or RUC in short, are nothing else than unit costs that follow a standardized method in the calculation, so that indeed everybody calculates apples. So this is precisely what we aim for in the PECUNIA project, where we develop a standardized and validated method to develop unit costs. The PECUNIA RUC Compendium is, in a nutshell, an electronic library where we collected all the RUCs that we calculated in the PECUNIA project. A basket full of labeled and quality-checked apples. It was a long journey to arrive at the PECUNIA RUC Compendium, and I will focus on the later stages that directly concern the PECUNIA RUC Compendium here. So first we had to calculate the RUCs, which we then bundled together in the first draft of the PECUNIA RUC Compendium. In the next step, we subjected the RUCs to a process of external validation to confirm that our RUC estimates actually make sense, something that we should never take for granted. After this process, including some back and forth and recalculation here and there, we tied together the final PECUNIA RUC Compendium for the end users. When calculating the RUCs in the PECUNIA countries, we aimed to arrive at unit costs that fulfilled the high standards that we formulated as desirable based on our previous research. First, we wanted unit costs to be representative for the whole country and not just for one region or one service provider. Second, we wanted those unit costs to be of high quality by following a top-down micro or gross costing approach. For this purpose, we either made use of national level secondary data, meaning that data was already collected by somebody else, or collected the data ourselves directly from the relevant service providers. Finally, in order to make the unit costs comparable, we adjusted them so that they are in the same reference currency, euros, and refer to a single reference year, 2019. A key challenge in countries where both publicly and private financed healthcare play notable roles is that private patients often face higher prices that may reflect differences in costs if the quality of the service is different, for instance, if consultations are longer. Essentially, this means having to calculate 2 separate unit costs, one for each case. But in general, we do not know who pays, so we need a unit cost that accounts for both cases. In PECUNIA, we solved this issue by calculating a weighted average of the 2 unit costs based on how many contacts happened in each setting. Consider Austria as an example. If a physician has a contract with your social health insurance provider, your visits to this doctor are covered by the public system. You can also go to a doctor who does not have such a contract, but then you mostly have to pay for yourself. Some patients still choose to do so because they like a particular doctor or they want to avoid long waiting times. And nevertheless, only a small fraction of healthcare service use in Austria happens in this setting, though this depends strongly on the sector in question. As you can see in general practitioner visits, these are by and large publicly financed, and hence the combined RUC is quite close to the publicly financed one. For dental care, the difference is a little bit more pronounced, albeit not by much. So now, once we calculated all the different unit costs, we proceeded with the next important step in assuring the quality of our RUC estimates, the external validation phase. We used 3 different approaches. First, we presented our results at scientific conferences to get feedback from our peers, but the COVID-19 pandemic unfortunately slashed those possibilities for this. Second approach was to seek proactive validation by either comparing the RUCs against existing UC estimates or by reaching out to experts and data providers directly for feedback on the RUC estimate. Finally, the Spanish RUCs are a little different as they are part of a work package that is fully dedicated to validation. But be aware that the external validation may not always be possible. The final set of PECUNIA RUCs is bundled together in the PECUNIA RUC Compendium, our Microsoft Excel-based electronic library with a complementary user guide. The RUCs of the different sectors are structured according to the PECUNIA costing concept, which is presented elsewhere in more detail. In total, the PECUNIA RUC Compendium contains 87 RUCs from 5 countries. We'll hear about the details of the RUC, the different sectors, in a little while. For now, I would like to conclude this introduction with a summary of what the PECUNIA RUC Compendium offers. The PECUNIA RUC Compendium is an electronic library of comparable standardized unit costs for relevant and unambiguously defined resource use items. It is connected with all the other useful PECUNIA output for researchers trying to measure resource use, like the PECUNIA RUM, the Resource Use Measurement Questionnaire, or the PECUNIA costing templates in the PECUNIA coding system. As far as costing tools go, the PECUNIA RUC Compendium is already quite intuitive and user-friendly. But to be really sure of that, we also added a comprehensive user guide that basically summarizes pretty much all you need to know. We also implemented a feature that signals when there are limitations to a RUC using a traffic light system, so you don't have to endlessly scroll through the fine print to figure out whether there are any caveats to a particular RUC. Finally, the PECUNIA RUC Compendium is designed to be a living document for the scientific community. The PECUNIA costing tools are free of charge for non-commercial purposes and can be accessed via the PECUNIA Project Coordinator. We only ask from researchers in return that they report back any unit costs developed with the PECUNIA tools so that we can include them in the PECUNIA RUC Compendium and thereby make them available to the broader scientific community, so that in the end, not so distant future, we are able to compare apples with apples at last. I will continue to talk a little bit about the RUCs in the health and social care sector, in particular how these compare across the PECUNIA countries. We are looking at 32 RUCs in the health and social care sector for 5 resource use items in 5 countries. We prepared a graph that puts the cost of the core set of health and social care services in different countries against each other. As you can see, costs for the same service can be very different when you compare countries. For most services, Hungary stands out due to its generally low level of costs, reflecting Hungary's lower price and wage level. But even countries with a similar price level, like Austria and Germany, show marked differences in the costs for some services, even when using a harmonized costing approach. But what is the cost for this difference in costs? We know some driving factors behind this cross-country variation. Most prominently, the PECUNIA RUCs do not adjust for purchasing power, as they are mainly meant to reflect the costs as they are in a country. Moreover, the scope of certain services might still differ between countries. Finally, how the healthcare system is organized or other country-specific peculiarities like the dental care tourism in Hungary may also affect estimates. Differences in costs also arise if the underlying data is not entirely comparable, even if the calculation method is harmonized. Sometimes you don't get the data in the quality that you want, be it due to a limited cooperation from service providers. For example, due to the sensitive nature of the data, or because service providers are not aware of the costs themselves. Collecting data yourself, you might then only arrive at small samples which may not be nationally representative. Even if you're lucky and somebody else has already collected the data, these secondary data sets may differ across country, again affecting the estimates. An example here in the PECUNIA project was the inclusion of expensive dentures in the cost data for dental care, which was not the same in all countries. The good news is that once you're aware of those differences, you can take them into account when you do valuation. To make sure that we captured all this detailed information, important information, we included the external validation process, which turned out to be an important step as it led to the recalculation of 5 RUCs in 3 countries. The outcome of this external validation is captured in our level of certainty index that reflects the quality of an RUC estimate, which you can see in this figure. And with that, I hand over to my colleague from the Netherlands to tell you more about the RUCs in education and criminal justice. Thank you for your attention.
Thank you very much, Michael. My name is Irina Pokilenko, and I will tell you about the RUC Compendium developed for Work Package 2, which combines 2 sectors, education and criminal justice. And for these sectors, we have in total 6 unit costs, 3 for education and 3 for criminal justice. And before I go on with my presentation, I also wanted to highlight that generally these 2 sectors have not received much attention in health economics previously. Therefore, it also made it a bit more challenging to find correct data and also do the external validation process for these unit costs. So for the education sector, we picked 3 previously identified services for the calculation of unit costs, which include educational therapy in primary school, education therapy in secondary school, and education services provided in a special education school. For the educational therapy in both primary and secondary schools, we already see a variation in the unit of analysis. So in some countries, we calculated unit cost per contact, while in other countries, the data only allowed to calculate the unit cost per day. Which is why those are displayed separately in the graphs. As you can see, there's already quite a lot of variation. And similarly to health and social care sector, the estimates in Hungary for these 2 services are the lowest, and in Germany is the highest. For the education services provided in a special education school, in the Netherlands, we actually were able to come up with 2 unit cost estimates, one for primary special education school and one for secondary education school. The highest estimate was in Austria and the lowest one in the Netherlands for the primary special education school. For the criminal justice sector, we selected 3 items, 2 services and 1 material damage. To be able to also validate the costing templates for material damage. So for the material damage, we selected car vandalism as an example and calculated the average unit cost based on several incidents. And we can see as well quite a lot of variation across countries, with the highest estimates in Hungary and in Austria. And 2 other services for criminal justice were night in jail and police contact. For incarceration, similarly, we see a lot of variation with the lowest estimates in Hungary and highest in Germany. And for police contact, we see quite a major outlier in Hungary, and we're still investigating what would be the reason for this. And finally, some key challenges for these two sectors. We can see quite a lot of cross-country variation for unit cost estimates. This could be due to differences in data collection practices, for example, what components are included in the data. Furthermore, there are quite a lot of differences in the systems. For example, educational system and criminal justice system across countries vary quite a lot, similarly to healthcare systems too. Regarding the availability of data, it was quite challenging to find high quality data to come up with unit costs. And we had to make a lot of assumptions. So for example, what would be the average number of students in a classroom, and also rely on proxy services to come up with the estimates. And finally, for car vandalism, it is important to note that while the unit cost reflects an average amount, what the incident would cost, however, each incident would likely be very different depending on the nature of the incident. So a very minor damage such as scratch on the car is not very costly, while, for example, a shattered car window can be very expensive. And this concludes my presentation. Thank you very much for your attention.
My name is Kimberly Hubens, and I'm a PhD candidate at the Erasmus University of Rotterdam, and I will be presenting to you the PECUNIA unit cost estimates for productivity cost of paid and unpaid work. The PECUNIA partners from Austria, Germany, Hungary, the Netherlands, and the UK have collected and validated unit cost estimates for productivity costs of paid and unpaid work, or relevant components of the productivity costs, and also the required data for the valuation of these costs, specifically on absenteeism and presenteeism, or absence from work and reduced productivity while at work, the friction period, which is needed for the valuation using the friction cost method, retirement age for applying the human capital method, and replacement cost for the valuation of unpaid work related productivity costs. At the time of this recording, the results from the UK are not final yet, thus they are not presented in this graph. We have identified some expected country differences. For instance, the relatively low estimates for absenteeism, presenteeism, and unpaid work for Hungary, and the friction period differs per country because the vacancy durations differ per country. The retirement age in these countries differs only slightly. We did not find any unexpected differences between these countries, and all of these estimates were found to be valid in our external validation process. In this project, we have found sufficient data availability for all but one item. We were unable to collect national data for estimating the friction period in one country. However, it must be noted that international data was available for this country. Also, international data could be used in future studies for the validation of estimates that are calculated using the PECUNIA productivity costing templates. Thank you.
Okay, so my name is Valentin Brodsky, and I will provide a short introduction to the PECUNIA Unit Cost Compendium for the patient and family domain. London School of Economics and Corvinus University of Budapest, jointly with the Medical University of Vienna, developed this Unit Cost Compendium and filled in with the country-specific data. 5 countries, Austria, Hungary, Germany, Netherlands, and the UK, applied the PECUNIA costing template to estimate national unit cost for the informal care time. And the unit cost were estimated by primary data collection in 3 countries, namely in Hungary, Austria, and the Netherlands. And two other countries, Germany and the United Kingdom, provided secondary published data as unit cost estimate. The compendium also includes information on external validation of informal care time cost for each country. And the comparative evaluation against the national minimal and average hourly wage was chosen as the external validation method. On the following slide, I would like to show you the unit costs that are included in the compendium. The unit cost for informal care time in the 5 countries presented in the graph. All unit costs were reported in euro for 2019. The unit costs per country are shown in blue bars, and the other 2 bars show the minimum and the average wages. The figures show, as expected, the unit cost differences between the countries. The lowest unit cost with 7 euros was reported in Hungary, and the highest with 27 euros in Germany. The average and minimum wages used for the external validation are shown in the brown and the gray bars. And you can observe that the unit cost does not differ remarkably from the average hourly wage and exceeds the minimum wages in all countries. So based on the external validation, the unit costs were classified as a good proxy for full cost in the compendium for all countries. So thank you very much.